We're back at the annual meeting in women's cancer, and another presentation just happened less than about an hour and a half ago. Can you introduce yourself and tell us a little bit about your abstract that you presented today?
Absolutely. My name is Amanda Nickles Fader. I'm a GYN oncologist based out of Baltimore at Greater Baltimore Medical Center and Johns Hopkins Hospital. And I presented an abstract today on a specific type of ovarian cancer. It's called low-grade serous cancer. And we talked about some of the factors that are associated with improved survival with this particular type of cancer.
Kind of walk us through just briefly. Low grade and high grade, somewhat of a new terminology of looking at, talk how that's changed in the last few years and how it looks like things are changing to really use the terms low grade and high grade and what that means to a patient who's been diagnosed with ovarian cancer.
Let me take a step back further to explain. So we know that ovarian cancer is one of the most lethal GYN cancers in the U.S., but we've made a lot of treatment advances in the last 20 years. And one of the things we've learned is that the type of cancer called epithelial ovarian cancer is the most common. And epithelial just means the cells that are on the surface of the ovary. And of the epithelial cancers, serous cancer is the most common. And what we've learned is that the serous cancers come in a low grade and a high grade form. And grade has to do with what the cells look like under a microscope to a pathologist. And so if the DNA or the nuclei of the cell look really ugly, or it looks like it's going to be growing rapidly, or it's a very atypical looking, that designates it as more of a high grade tumor. It has more propensity or risk for growing fast and spreading, whereas low grade it's not as atypical. It grows a little bit more slowly, a lot more slowly actually, and survival seems to be better with the low grade variety because of some of those factors.
What are some of the, you were looking at specifically some of the treatments that are showing for longer, obviously progression-free survival and overall survival of these. What are some of the things that you talked about today?
So we talked about the role of surgery and chemotherapy with these tumors. And with the high-grade serous cancers, which are actually more common than the low-grade, we know that a combination of surgery and treatment, surgery and chemo are very helpful. However, with the low-grade variety, one of the problems, even though they do better overall than the high-grade tumors, is that they don't respond as well to chemotherapy because chemotherapy works on rapidly dividing cells, and these cells just don't divide that rapidly. And so it seems like the cornerstone of management for these patients, for low-grade serous carcinoma patients, is surgery. And so what we talked about in our study today was the importance of surgical cytoreduction. And what that basically means is that we remove all the grossly visible tumor that we see in a woman's abdomen or pelvis, or attempt to remove all the tumor that's safe to remove. And if we remove all of the tumor, that's called microscopic residual. We can't see any tumor there. There might be some microscopic cells floating around, but we did our best effort surgically. We break it down into microscopic residual, optimal, less than 1 centimeter, which I referred to today, which means that you might still have some residual disease of less than 1 centimeter in size, and you can have multiple little implants like that. Or suboptimal residual, which means we leave more tumor behind than we'd like. So,
for women who are going into their first treatment, first surgery, what are some of the questions they can ask of their surgeon that might help them to get to the place where they are starting to understand how their surgeon's going to react to when they get in there, to getting to optimal debulking?
Well, any woman who is diagnosed with ovarian cancer or has a suspicion for ovarian cancer should absolutely be seen and treated by a GYN oncologist. We have multiple studies that demonstrate that there are improved survival outcomes for women who are treated by a specialist in ovarian cancer, and that would be, again, a GYN oncologist. Even better outcomes than treated by a general surgeon or just a general gynecologist. And so finding a good subspecialist in a woman's area is the first most important step. The next step that a woman's gynecologic oncologist might do is do some preoperative testing to assess where the tumor is, how much there is, with a CT scan, maybe test a tumor marker, the CA-125, and that will give the surgeon some important information about the likelihood of being able to achieve an optimal surgical effort. We can't always tell, though, with CT and CA-125. Sometimes we have to look inside to know for sure, but an experienced GYN oncologist, and 60 to 80% of the time, will be able to achieve a good optimal cytoreductive effort on a patient, and that goes a long way to improving her progression-free and overall survival.
Lastly, you mentioned in some of your charts you were talking about ascites specifically, and that with low-grade cancer. Explain a little bit what ascites is, and then what some of the questions women might ask about that and what that means for prognosis for them.
So our body is composed almost primarily of water. Over 80, 85, 90% is water, and the water exists in different compartments of our body, but it can shift into compartments it's not supposed to be in when there are things that aren't supposed to be there, like tumors. And tumors can secrete proteins that draw fluid in from other spaces in the body, and that is what's called ascites. When you can have a very large volume, 1, 2, 3, 4 liters of extra fluid in the abdomen around all of the abdominal organs, it can be extremely uncomfortable for a woman, and it's a byproduct of the tumor. Yeah.
What's it mean for prognosis for women? What are some of the things that you're learning about when we find ascites in the surgery?
Ascites is fairly common for women with both advanced high-grade or low-grade carcinoma, so it's difficult to know exactly what the prognostic effect is. We found in our study that it may be an adverse prognostic factor for survival, meaning that it might be more difficult to achieve an optimal cytoreductive surgery when there's a lot of ascites present. But I have to caution about the results of the study because there was only 189 women studied, and so we need more data to know if that is truly a prognostic factor or not.
Lastly, what are some of the next steps for surgical, moving forward in surgical cytoreduction and debulking? What are some of the things that are really moving forward in ovarian cancer?
I think being able to predict which women will be able to achieve an optimal surgical effort in, and those we will not, so that we can spare women who may of any surgery if we're not going to be able to achieve that, because we know that survival is so much better when we get to that microscopic residual disease. So biomarkers or predictors, blood tests, other factors, better imaging is, I think, going to be the wave of the future. And then studying what we call biologic or targeted therapy, specifically in low-grade serous carcinomas. These are chemotherapy agents that target specific proteins or receptors on the cancer cell that can help inhibit its growth. And so these are very hot right now, and we're exploring them and learning more about whether they're going to have a big role in the treatment of low-grade serous carcinoma.
Thank you very much. That was wonderful.